All right, we're going to go ahead and get started. Apologize running just a little bit late and having a little bit of internet connectivity problem today. For those of you that are here last week, you saw that I was having some issues then. I think we should be in a decent spot. If the quality is terribly poor, I will have this recorded and sent out to the people who attended. You should get an email with that link tomorrow at some point. But I did want to go ahead and get started here. One thing, you should have a Q&A or a chat button during this time that we have together. If you have questions, my moderator can touch base with me and let me know if there's questions I need to answer. Or even another thing I was thinking is if there's additional content that you would like to see as part of these webinars, feel free to let me know. I've got a fairly structured schedule at this point, but I can certainly look at other things to add in. It's not developed what we're going to do for 2021 yet, but I can throw some more stuff in there as we need. All right, so let's go ahead and get started here. And I'm just going to walk through this. An hour isn't a whole lot of time to cover a whole lot of content, so I'm going to go fairly quickly. Again, you'll have access to the recording, so that should make it okay. So we're going to do dry needling for tennis and golfer's elbow, medial lateral epicondylitis. One of the things that we see all the time in the clinic, traditionally 15, 20 years ago, it was something that took us a good bit of time to reduce that pain and inflammation. With the advent of implementing dry needling into the program anymore, we find that our treatment times with these conditions is significantly shorter in moving a patient onto a home exercise program and so forth from there. So we're going to take a little time to talk about what the tennis and golfer's elbow protocol is, would be beneficial for, and then what diagnosis and conditions, which those are fairly self-explanatory, and how it was developed. Take a look at some three-dimensional anatomy to determine exactly where the tennis golfer's elbow protocol would be applied to the structures. And then we'll review a quick review of precautions associated with dry needling. Then we'll review relevant surface anatomy and look at the dry needling procedure for the tennis and golfer's elbow through that protocol. And then again, if you have any questions during this, hit the Q&A or the chat down below, and I'll try to address those as time allows. Conclusion, again, I'm going to make this content available online for those who wish to see this again. So the conditions that would benefit from tennis and golfer's elbow, fairly self-explanatory, tennis and golfer's elbow. I do find that I use any of the other issues in and around the elbow, whether it's specific to epicondylitis or not. I will use this and implement this into the different treatments that we do. But possible problem areas is in focus of treatment. So the cool thing is I did not update this slide. So you're not going to use this for the lumbosacral junction or sacroiliitis or any of those structures. But so the structures that we would be considering would be obviously all of the individual flexors and extensors. We'll talk about the perineural dry needling that could be associated and be a part of it. But yeah, if you've got a diagnosis of lumbosacral, probably the elbow is not the place to dry needle. Let me move forward. Thank you. And again, back pain is not the situation. Let me frequently get through that. Wow, I apologize. I hope I got the rest of this in there. Again, do not needle those for your elbow problems. All right, we will cover all of those muscles here momentarily. Precautions, just in general, non-consent from the patient, medical legal reason on the first trimester of pregnancy, nipples, umbilicus, external genitalia, a big one, a Chiari malformation if you're needling suboccipital region, and then into a site with post-surgical lymphedema. Some relative contraindications post-surgical, 6 weeks with communicating tissue, and then 12 weeks into the local specific area, unless surgeon gives permission otherwise, which some will, some won't, just up to the discretion of the surgeon. And then some precautions, just needle aversion or phobia if there's a significant cognitive impairment. if there's a history of traumatic or spontaneous pneumothorax. Obviously, that's always one of our big concerns, is if there is an issue going on with that. We never want to hit that area. Fortunately for the elbow, if we're hitting the lung field, then we've really got a skill set problem. So perineural dry needling, we'll talk about this just a little bit as we get towards the end. Median radial ulnar nerve can come into play with a problem, tennis elbow, golfer's elbow. It's not always involved, but we're going to be in those general areas anyway. If just not getting the symptom resolution that we're looking for, may need to look at those perineural protocols, and I'll review that with you briefly at the end. Let me skip through this information. One thing, there is a sparsity of evidence concerning the mechanisms of perineural dry needling, and a lot more needs to be done there. But anecdotally, we are seeing good results with that. Again, I frequently will include a perineural approach to any of my needling protocols that are out there, especially if it's a complex problem. So let's look at the surface anatomy, and I'm going to hit just the basics here with dry needling. That's kind of where we are on the lateral aspect. So number one, we want to be able to find, if you can see my arrow, have to be able to palpate the lateral epicondyle without a doubt, because that common flexor, common extensor tendon will insert right on the distal aspect there. Additionally, we need to be able to palpate the supracondylar ridge. We will have two of the muscles, brachioradialis, extensor carpi radialis longus, will attach in that area. We still will needle it because it's part of the extensor group, but its attachment is superior to the epicondyle, where the tendon itself is located. Again, the tendinous attachment will be more on the capitulum of the humerus, and so that is palpable. You can find that border, and then find the notches that identify the distinction between the humerus and the radial head. Again, we discussed the brachioradialis is going to be attaching in the proximal 2/3 of the supracondylar ridge that we can palpate. And then below that, the extensor carpi radialis longus we'll be able to find in the distal aspect. So this next section goes through talking about how to locate and identify your different muscles that comprise the extensor group. I'm not going to go through each one of these clinically. You can come back to the slide, and it'll tell you what you need to know. But also, as we go through that, then so once we get into the needling, we won't want to be having the patient move the fingers to identify. It's a little uncomfortable, and I've got video that shows the entire needling protocol, so you'll know once we get to that. But brachioradialis, ECRL, ECRB, fairly simple to identify. Get down to extensor digitorum. They can play the piano. Easy to drop that out. ECU, have them dorsally extend and then ulnarly deviate. As you palpate, you can identify that. It just is going to pop right up, similar to with Anconius. Anconius isn't involved that often, but it is one of the muscles that falls into the group. So good to be able to identify it and needle it when necessary. So some 3D anatomy of the tennis elbow. Here's a quick little picture of our needling locations, and we'll break this down much more specifically. As you can tell, we get onto the epicondyle, onto the common tendon itself, and then we're going to target each individual muscle in a line as it goes onto the lateral extensors right there. But give me 1 second. I'm going to move from here over to here. All right, so I really enjoy and appreciate a three-dimensional anatomy program. There's lots of them out there. A lot of them are good. I have permission from the Complete Anatomy group to use their software in both my lecturing and in the webinars and content. So again, it's one of my favorites. But as we do look at this extensor group, I have marked our location here with our, again, brachioradialis, ECRL, ECRB, flexor dig, extensor carpi ulnaris, and then inconius. So when we do this, we are going to want to hit all of those structures individually. I say that. Initially, my very first treatment approach is I'm going to group all of those muscles as a single unit, and I'm going to thread through the entire bundle of groups, grouping of muscles, so that I can hit all of them with a single needle, and it's less invasive for the patient, less of a shock. Most of the time, that's as in depth as I have to get with tennis elbow and for golfer's elbow. But when it is an issue, I will go ahead and I will break them out individually. If there's a return visit with still those residual symptoms, so then I'll come back and hit all of those. But just a quick little review there of how we're going to get to that area. We're going to find the bicipital crease, the cubital crease. Then we're going to go just about 3 finger breadths distally, and then we're going to go just in a nice line towards the posterior aspect here, and make sure that we get all of those muscles using the ulna there as our posterior border. So let's jump back again. So for our treatment lab, what we're going to do, and I'm going to just kind of break this out really quickly, for the common extensor tendon. Well, number one, in the red dot right here, we are going to hit the lateral epicondyle. There's no muscle, but there is connective tissue, and a lot of times that is the point of discomfort. We can needle onto that, get a good response, and get some healing, some blood flow into that area. Always a nice approach. If there is some tearing in the common extensor tendon, it will be very close here. So up to 2 finger breadths distally from the lateral epicondyle, we can come down and needle into that area. I may do some pecking through here and cover a whole line, or I may just drop a specific needle in one location. Just depends on patient tolerance. Again, just coming 2 finger breadths distally for common extensor tendon. For the brachioradialis, again, I'm going to find the cubital crease. There, we're going to look at about 3 finger breadths distally from that. And we're going to, again, previously identified brachioradialis by pulling the thumb up, and it'll pop up right there for us. And then we can take that and we will needle toward the radius. We don't have to use radius as a backdrop, but we can. The key there is identifying that first big muscle group or belly, and then we're going to go laterally from there. So we move extensor carpi radialis longus. Again, we're 3 finger breadths from the cubital crease, and now you're going to find about every finger breadth as we go laterally towards the ulna that we're going to move and drop a needle in that location, again using bony backdrop if necessary. Normally I'm going to use about a 3 centimeter needle here. If it's a larger person, I may go with something more. It's not really necessary. 3 will take care of it. We're going to go a little bit further into the extensor carpi radialis brevis. You may find we need to come down a little bit further distally from the radial head here to get into that muscle belly. Again, in a nice straight line as we're coming down. Extensor digitorum, if you have to, you can have them play the piano. Once the other needles are in place, I wouldn't recommend that, but if you want to absolutely know where we are, that can be done. Again, from the radial head, we're going to come down 4 finger breadths for that. And then extensor carpi ulnaris. Again, another 4 finger breadths distally, 1 finger breadth again away from the previous muscle as we're headed towards the ulnar border. And then supinator, we can definitely drop needle in there. It'll be 3 to 4 finger breadths distally. Decent odds we will have hit that with the previous musculature, but if we want to go ahead and drop a needle specifically for that, we can do that. Again, about 3 to 4 finger breadths distally from the radial head in a line. And then inconius. Again, I like to be able to needle it. It's not all that common for it to be clinically relevant as far as our pain dysfunction, but since it does share the common attachment, we will hit that. We'll take 2 finger breadths distal and 1 finger breadth lateral to the olecranon process, and then we'll just drop down into that muscle right there. So we talk about, when I discuss dry needling, I will usually do my protocols in stages. And here our first stage is going to be the lateral epicondyle and then the tenoosseous junction. Our secondary is going to be brachioradialis, ECRL, ECRB, and extensor dig. And then thirdly, extensor carpi ulnaris and then coneus. We can also, because it could be involved, we could do a perineural radial nerve protocol that we'll look at. And if we really want to, we can come more proximally and look at the segmental innervation at C5, 6, 7, 8. I will almost always provide some electrical stimulation, whether it's a prolonged stimulation. We can do that like a burst of anywhere from 2 to 3 hertz up to 75 to 100, alternating back and forth every 3 to 5 seconds. First visit, normally I'll just use a little point stimulator, give them 10, 15, 20 seconds of stimulation, and that's usually my approach on the first visit. As if there's a follow-up, then I want to get a little bit more in depth with that electrical stimulation piece. So on this model, this is basically what this looks like. Our primary needle locations we'll catch here. Again, my very first time, I'm going to come in and I'm going to needle across all of the muscle all at one time, going under the assumption it's just a mild strain. And if we can reduce the tension in the muscle concept, bellies itself, then we can reduce that. And then most of the times that's enough. I do that, give them a little home exercise, some flexibility work, some strengthening, and restore normal movement, and then we're good. I get to this level whenever they have some residual symptoms. So our primary locations coming across from the cubital crease, the other muscle locations, kind of all in a nice little row, 1, 2, 3, 4. And then our tertiary for extensor carpi ulnaris and coneus on the others. So 1, 2, 3, 4, 5, 6, 7, 8. You know, it's a lot of needles, but it covers everything that has to happen. All right. So for tennis elbow, treated as a group, we're going to look at the muscles of brachioradialis, extensor carpi radialis longus, and then brevis being the first one that actually attach onto the lateral epicondyle. Then we'll look at extensor digitorum, extensor carpi ulnaris, and then occasionally we will deal with coneus a little further distally. So several positions or locations that we want to needle. The very first part is onto the lateral epicondyle itself. So, and before I do that, one general comment: whenever I'm treating tennis elbow, I normally will thread through the entire bulk of this muscle with a single needle as opposed to hitting each of the individual muscles themselves. So first session will always be just needling the bulk of the muscle. And then the second one, if symptoms haven't completely resolved, then we'll move on to this approach. So first, just directly onto the lateral epicondyle. It's going to be very superficial, but it is important to the terminal aspect of the common tendon to hit that area. We're going to drop down a little bit distal to that, to the actual common tendon, and we'll needle into that part as well. To right there. Again, fairly superficial, because that's going to sit right there. And then we'll look at the muscular pieces. We're going to move a few finger breadths distal to the cubital crease, and we can follow. Now the hard part is we have to test all of these muscles prior to putting needles in. If I were to test these muscles right now, she would not be happy with me having her do all of these motions. So we know brachioradialis comes and attaches on the supracondylar ridge. We're going to drop down a few finger breadths, and we're going to needle towards the radius here. Depending on the length of the needle, we may hit backdrop. If we do, that's perfectly fine. We'll drop down on the supracondylar ridge into the lower third for extensor carpi radialis longus. And we'll needle there. We'll drop a little further, and we can palpate for extensor carpi radialis brevis. And as you can see, I'm going to go in a straight line with each of these needles. A little bit further, if I so choose, and I do choose, we can have her play the piano very gently, and we can identify extensor digitorum. To there. lastly, clinically, I may go ahead and needle into extensor carpi ulnaris. So I identify the border of the ulna, come just inside that, and needle to there. For tennis elbow, that will provide the bulk of the needling placements that I need for tennis elbow. All right. So from there, let's move on to the medial flexor group and the golfer's elbow or medial epicondylitis. So a few more things to look at here. Again, the medial epicondyle, the medial supracondylar ridge gets a lot more difficult to identify, but mainly because it dives a lot deeper than it does on the lateral aspect. Also have to be a lot more careful because of the neurovascular bundle that sits in there. Fortunately here, we're not going to be needling up anywhere higher, just onto on the medial epicondyle and then below on the common tendon. So we need to be able to identify those. Again, the way we want to come in, we want to be able to identify the pronator teres, the biceps brachii tendon will be part of our landmark as far as our distance. Again, from there, we're going to come 3 finger breadths, 3 to 4 finger breadths distally from that to determine needle placement. And then the bicipital aponeurosis, we can palpate for that. Don't have to be able to differentiate that as far as our needle placement. However, we don't have a whole lot of structure. We're concerned on the anterior aspect. As we get further around to where the ulnar nerve sits, then we start to get a little bit more cautious with that. And then let's move there, median ulnar. Okay, so as we look at our general needle placements, let me move on to back. Let's come back and share really quickly. Where are we? We are here. All right, and bear with me. Let me jump to my library. And change from tennis to golfers. All right. So here, similar. What we want to look at on this medial side is we're gonna palpate medial epicondyle, the common flexor tendon, and then fewer structures that we have to deal with that actually comprise the common tendon itself. We will hit pronator and the remaining musculature as it's coming around. We will needle into the flexor carpi ulnaris. We want to be cautious given the location of the ulnar nerve, but absolutely can be a big issue on golfer's elbow. So let me drop back out of there and let's come back to our slides here. So again, the common flexor tendon, the tenoosseous junction, again, it's palpable. We can palpate that for the epicondyle. We will find that we will needle directly onto that and get a good benefit. For the common tendon itself, we'll drop a finger breadth, and we can needle along this inferior ridge of the epicondyle into the tendon where if there is a tear, it's more than likely going to be located there. Again, we'll use a 3 centimeter on most all of this musculature. On the pronator teres would be our first that we'll go at. So interestingly, we've got a nice little V notch that's made by the brachioradialis and the pronator teres, and that's where our bicep brachialis group come into their attachment. So frequently, whenever, again, if I'm going to needle this initially, I'm going to needle across all of this musculature at about this same location for pronator teres. So it's 2 finger breadths distal from the cubital crease, and we'll just make a needle placement and advancement away from midline. That way we miss all of the critical neurovascular structures that could be more in midline. And that's a very good initial treatment approach there. Again, problem patient, symptoms are still remaining, then we want to get very specific with our needle location. So similar, we're going to go in a straight line from medial to from midline to medial or away from midline for the flexor group. So 2 finger breadths distal. We'll move further to flexor carpi radialis. There will come down 2 to 3 finger breadths from the cubital crease. Again, it's going to be about 1 finger breadth medial from where we needled for the pronator teres. We identified pronator teres by resisting pronation to identify that medial muscular border. And then we're going to follow it 1 finger breadth further medial to each of these muscles. Palmaris longus, we can identify that from the midline all the way to its attachment at the wrist. But again, it's going to be about 1 finger breadth medial from the previous muscle. And we're going to keep going to flexor carpi ulnaris, as it is, again, maybe 3 to 4 finger breadths from the medial epicondyle, but in a nice little row from midline to medial to get all of that musculature. You may want, odds are we're going to catch flexor digitorum superficialis as we're needling the other musculature. If you want to identify it, you can definitely hit it. It's midpoint between flexor carpi radialis and palmaris longus, and it's at a midpoint in the forearm. You can identify that specifically if you want. Again, odds are we will have landed a needle through that muscle as we're coming from midline to medial, 1 finger breadth as we go. But it can be identified specifically if we choose. Similar for flexor digitorum profundus. Odds are we needled that, but if we choose, we can target that. Clinically, I probably don't ever specifically target that if I'm going after individual muscles, because I know I will have needled into that already. So let's move in and look at our primary, secondary, and tertiary structures. Our primary, again, the medial epicondyle and the tenoosseous junction. And then we'll look at so here we're going to hit the flexor group itself, which is going to be pronator teres and the other 3 muscles we talked about. I'm not going to come catch distally or even down to the pronator quadratus. So we talked about the muscles from HMDN1. That's my first, when I teach a class, that's my first grouping of the common flexor muscles. So it is basically just these initial muscles here. And tertiary, we can come down and get pronator quadratus. I've never found clinically that it provides me any additional treatment benefit. However, we know how to needle it if necessary. So again, we're going to catch the epicondyle, common tendon, and then the muscles all in a nice little row as we come down. It doesn't really represent it here, but it is in a row as it moves down. All right, so, and then a little demo. All right, for golfer's elbow or medial epicondylitis, similar to tennis elbow, first time treating this, I'm probably going to take a single needle approach to needle through the bulk of the common flexor musculature to see if we get a good response out of the muscle tension in that area. If it's necessary, they return and need to come back and needle some more. Then I'm going to start with the medial epicondyle, and I'll locate that. Before I do that, I want to make sure, once I start placing needles, I can't have a person test their muscles to identify them. So I want to come through and identify my pronator teres, flexor carpi radialis, palmaris longus, the flexor carpi ulnaris, and the flexor digitorum superficialis. So I need to have a good idea of where those muscles sit before I start needling these. But again, I'm going to start with the medial epicondyle. We want to be cautious with the ulnar nerve as it travels right in that general vicinity between that and the olecranon. So in this case, because this is the location of the attachment of the medial flexor group, I do want to come in and needle directly onto that structure. It's going to be very shallow. I'm going to move and needle into the common flexor tendon, so all of the muscle is coming up to attach there. I'm going to drop just off of the epicondyle into the tendon. I'm going to move and needle into pronator teres. I'm going to move just a few finger breadths distal from the cubital crease. And in the anatomical position, the flexor piece is going to sit with pronator right here. In this position, basically down toward the table. We'll move from there to flexor carpi radialis, which is just going to be a finger breadth and a half away from the first needle. Again, I'm going to go basically in a straight line. Flexor carpi ulnaris, a little further, or palmaris longus. Sorry, again, the distance is going to be fairly equal. Again, I will have tested palmaris longus previously, and it'll come right here. I'll drop one more down for flexor carpi ulnaris. I can identify the ulnar border and split the difference between that needle and there. That lets me skip the ulnar nerve. Can needle right there. And the last one for the flexor digitorum superficialis, I may have needled through that with one of the last two needles. I'm going to isolate it just a little bit more, and I'm going to drop 3 or 4 finger breadths down and needle right there. So that's all the needle placement that I need to effectively dry needle for golfer's elbow. The common flexor tendon, so all muscle is coming up to attach there. I'm going to drop just off of the epicondyle into the tendon. I'm going to move and needle into pronator teres. I'm going to move just a few finger breadths distal from the cubital crease, and in the anatomical position, the flexor piece is going to sit with the pronator right here. In this position, basically down toward the table. We'll move from there to flexor carpi radialis, which is just going to be a finger breadth and a half away from the first needle. Again, I'm going to go basically in a straight line. Flexor carpi ulnaris, a little further, or palmaris longus. Sorry, again, the distance is going to be fairly equal. Again, I will have tested palmaris longus previously. It'll come right here. I'll drop one more down for flexor carpi ulnaris. I can identify the ulnar border and split the difference between that needle and there. That lets me skip the ulnar nerve. Needle right there. And the last one for the flexor digitorum superficialis, I may have needled through that with one of the last two needles. I'm going to isolate it just a little bit more. I'm going to drop 3 or 4 finger breadths down and needle right there. So that's all the needle placement that I need to effectively dry needle for golfer's elbow. Okay, so for those of you who are thinking and asking why I'm not wearing gloves, my gracious model for our presentation is my wife. So she was kind enough to let me keep the gloves off, needled her quite a bit. You saw a nice bruise in her cubital crease. She had given some blood the day before, and she really bruised up. So that was not my fault. That was somebody else's fault. So. Okay, so basically tennis elbow, golfer's elbow, that's the needle placement for everything that happens there. Mentioned that we may want to throw on a little perineural protocol, median, radial, ulnar. Radial is for tennis elbow, and the median and ulnar can be a part of any of that other side, the flexor group. Just briefly, just kind of walk through this with a median nerve. I will follow basically the median nerve as it comes from the cubital crease and the lateral aspect on down underneath the palmaris longus as it dives down, and there's fairly specific needle placements that we look at to innervate that. We can also hit any of the, I think on the next slide, it does, no it doesn't. So we can also hit any of the muscles innervated through the median nerve as well to get an additional response out of that. Similar in the radial nerve. We can follow two general zones. I'll start up with the higher one first. So we can hit, triceps. We hit specific locations as we're following the course of the radial nerve down. With our perineural protocols, we're not trying to needle the nerve itself. We just want to get into proximity so we can get a good stimulation and response coming back to it. So that in the upper aspect, and then coming down, what it looks like here as we travel into the cubital crease. And then we come down also for the ulnar. We can have a further distal at the ulnar as it's coming into the wrist itself. But definitely there's a nice way that we can needle the ulnar nerve more proximally. Sites of entrapment of the ulnar nerve tend to be either right underneath the flexor carpi ulnaris, or there's a ligament a little bit deeper. It sits about right here. That's probably a little bit more responsible for the actual entrapment. So more than likely we can needle the bony surfaces, and if we're really aggressive, we can move just a little bit midline for some tinting, for some collagen wrapping around that needle, and for some tissue mobilization. But for the perineural protocol itself, just trying to get some stimulation through that nerve, following the path as it comes on down, is usually a really nice approach for that. As far as dosage and frequency, if you've watched any of the webinars before, you've heard me discuss this a little bit. Dosage and frequency is definitely unique for every patient, but typically can be divided into 5 categories, with dosage and frequency determined on their activity level, the chronicity of the condition, and their response to treatment. Probably the most important factor is compliance of a patient to a well-developed home exercise program. Yeah, I'm a massive believer in dry needling as a treatment modality to address the first phase of healing. That being said, it's only a modality and it's not the cure, and belief that is a cure is just false. Dry needling is needed, as is any other modality, to address a neuromuscular response to a biomechanical dysfunction. And that dysfunction can only be addressed through a change in mechanical function, flexibility, and strength. When properly applied, however, dry needling can be the most effective tool that we have in our arsenal to address that phase 1 of healing, which is the inflammatory response. So what are the 5 categories? Number 1 is the athlete, and there are 2 pieces of the athlete. One is an athlete that has no comorbidities. Issue is brand new, just happened. They haven't had a significant deviation from their strength or their performance level. These folks, we're going to dry needle them 1, 2, or 3 times within the first week. Here, their prognosis is excellent. They're going to be able to resume normal training and performance within 2 to 4 days because they haven't had a change in their mechanical function. The other athlete, they've got 1 or more comorbidities. The issue has moved to a subacute stage, which is 14 days plus, and they've begun to have some sort of asymmetry in their strength and performance. They're dry needling probably 3 to 6 sessions within the first 1 to 3 weeks, or 7 to 21 days. Again, prognosis is excellent. They will need 2 to 3 weeks of some training to restore their asymmetries, and then they can resume performance training, and their prognosis is going to be good. The average Joe, which is your weekend warrior, they're in decent physical shape. They've had some incident that resulted in a strain or overuse injury of a localized muscle or a group of muscles. We're going to needle them 1 to 3 times within the first week. Again, prognosis is excellent, but they will need to adapt an ongoing home exercise program to address the mechanical deficit that set them up for the injury in the first place. We've got the quick stick, and this is your work colleague, someone who's slept wrong, someone who's just looking for a quick fix. We're just going to needle them 1 time. Their prognosis is only fair, however. They're going to have some sort of underlying condition that will need compliance with some sort of an HEP to correct it, but they won't be willing to accept this fact to be willing to do the work. There's a very decent chance this person will become the procrastinator. The procrastinator, they have 1 to 3 comorbidities. They've been dealing with the pain and function complaint for several years. They're unable or unwilling to deal with the issue due to a variety of either valid or invalid reasons. Now they've decided they've had enough, they're ready to do something about their problem. We'll dry needle them 8 to 12 sessions within the first 30 days. Their prognosis is good, but their success depends on their compliance with their home exercise program. Again, the dry needling isn't the answer. It just knocks the pain down. It lets us get back to normal function if we so choose. So that's where their dependence or their ability to get to a good prognosis is, if they're willing to do their HEP. And then finally, we have the hard case. Here, there are multiple comorbidities. There's severe OA, degenerative joint disease, and there are other issues that really require surgical intervention or other intervention that cannot be done due to medical or personal issues, such as they can't get cleared for surgery due to pulmonary or cardiac issues. Frequency of dry needling here, they're going to be looking at 8 to 12 sessions for the first 30 days, 4 to 8 sessions for the second 30 days, and then 2 to 4 sessions from that third 30 day and beyond. So basically prognosis is fair. This is long-term maintenance. Insurance may be an issue and require a cash pay situation. Treatment will be required until interventional clearance is obtained. Again, it's non-pharmacological pain management. The dosage may have to be adjusted based on their condition, and treatment should improve functional outcomes, but withdrawing or discharging the service will result in a return to a prior condition. There's limited improvement with a progressive HEP. We see these folks. There's not much that can happen. They can't have surgery. Their pain is staying at a 5 to a 7. And you know, they're the people that are going and seeing the pain docs. They're on the heavy pain meds. If they've got an idea they want to come off the pain meds, we can help with that, but it's going to be a long-term situation and you have to deal with it accordingly. So if there's any questions, it is 12:43. If there are any questions, I will try to get to them when I send this email out. I will update this and I'll put it on our YouTube channel. If you have any questions, if you have any ideas of some other content that you'd like to see, feel free to send that information on to me. We do have upcoming webinars. This one is all the way to August 13th, so I get a little bit of some downtime. There we're going to be looking at the IT band syndrome and everything related with that. We'll look at it from the lumbar spine all the way down to the knee. In September, we'll look at subdeltoid subacromial bursitis. Basically, we're going to look at shoulder impingement and all the pieces that go on there and how dry needling can be effective with that. I use dry needling almost exclusively to deal with the pain and the limitation associated with impingement, that it makes it so much easier to get that good rotator cuff function, shoulder arthrokinematics back to where it needs to be. So the shoulder impingement. In October, we'll look at plantar fasciitis, something we probably see. I know I see a lot of it. We'll look at the proximal treatment in the calf itself and the muscles of the long tendons that go to the plantar surface. We'll talk about the most common issue related to plantar fasciitis and what's the most common culprit of pain and dysfunction. In November, we'll look at thoracic outlet syndrome, a lot of the structures that we can dry needle. Again, similar, and thoracic outlet is a perfect example. We can do a lot of good work with the dry needling, but it's not a substitute for restoring movement and motion. We're going to have to also apply some hands-on, some manual therapy to get that area functioning well. And then in December, we'll look at one that I see tons with, the pes anserine bursitis, medial aspect of the knee. A lot of that degenerative stuff that happens, we tend to also see that pes situation rear its ugly head. So we'll look at that again in December. And if you do have any questions, issues, feel free to look at our YouTube channel. I will send that out with the email tomorrow. And if there anything else, feel free to send me a message and we will move on from there. Hope you have a good day. Thanks for stopping in and watching.